Welcome to the ICPO studio. My name is Odile Jaume. I'm CEO of the ICPO Foundation, and I'm very happy to be here today with Dr. Erik Briers. Erik is a prominent cancer patient advocate who serves as Chair of Europa UOMO, a leading European coalition representing prostate cancer patients. He holds a PhD in chemistry and has a career in laboratory medicine. So, welcome, Erik. Very happy to have you here today for this special interview.
Thank you.
Drawing from your own experience as prostate cancer patient, you have become a powerful voice for patient-centered care, awareness, and early detection across Europe. You also actively collaborate with healthcare professionals, policymakers, as well as patient organizations to promote better access to information, screening, and treatment. Through your efforts at Europa UOMO, you have helped shape European health discussions, ensuring that the patient perspective remains core in decision-making processes. Could you explain us in your words what is the mission of Europa UOMO, and could you expand a little bit on those words?
Yes, of course. So Europa UOMO is an umbrella organization, which means that we represent patients throughout Europe who are themselves members of their own local organization. If we look through this membership, then we see that there are more than 100,000 prostate cancer patients linked to Europa UOMO, for which we feel responsible in a way. It is very important that we see it that way because Europa UOMO is not having contact with patients that are our members. But we have to give service to our members so that they can do the best they can for the patients themselves. And this goes very, very far. It is on making on the awareness, making the patient understand what phase of the disease they are in, giving them peer-to-peer support. So a lot of things that they can do for their patients, they can learn with us. Because we are just central to it, and we are not there except to act at the European level to give them the tools and the knowledge they need to be effective for their members. Just as key objectives and as important point for us, that is of course screening. For more than 20 years, Europa UOMO has a little more than 20 years. We want this screening done. And not just screening. We have this Praise You project in which Europa UOMO was an active participant, where we have been testing, piloting a system of risk-based, population-based screening for prostate cancer, which we want to see evidence-based and then rolled out throughout Europe. But that next step, that will be a major issue, a major problem, because it has to be done in the member states. So our members then become the pivotal points of getting this system in place in all these different member states. And that's one of our focal points. We have others, but this is so important and linked to awareness. Because unfortunately, most men, up to the moment they are diagnosed with prostate cancer, don't even know that they have a prostate. So we have to work on this knowledge so that as of a much younger age, men know their own anatomy. Today they know the anatomy of their girlfriends, of the women, but hardly anything about what's inside the male body and so important for their reproduction. So that is a point of awareness where we have to work on. And it makes no sense to ask a man to go for a screening if he doesn't even know the organ involved. So that is, screening is linked to awareness. But it's also linked to treatment. Because many men in this screening will be diagnosed with what we call a low-risk cancer, which means it's a cancer that has a very low risk of developing into something really dangerous. So for these patients, we have a perfect solution. That's active surveillance. So we will monitor them, and if the cancer turns bad anyway, it can happen in percentages, then the patient can still be treated actively. So these are 3 of our key points that we really are engaging in, but there are many more.
You have personally co-founded Europa UOMO and contributed to its growth. What are your highlights of key successes for patients along the last few decades?
Well, one of the issues is, of course, you can create an organization, a European level organization, but creating it is not what makes it. What makes it is the membership. So one of the highlights and one of the most important aspects is that we have been able to grow from an organization representing patient organization in, let's say, 15 countries to almost double that, which also means that our reach is much bigger. If we can roll out something in Europe, it gets across Europe. Quite the full EU is then covered. But at the start, that was not the case. So that is one of the very important highlights. We have also learned that Europa UOMO has an important position at the EU level. So we cannot ask members from, let's say, Slovenia to act in Brussels. That's our role. We act on behalf of our members, for instance, at the European Medicines Agency, and we have our place at the table. This is also something that does not come overnight. So there has been work done. We have to prove that we are an independent patient group, which means we are not depending on, for instance, industry. We are not depending from our professional colleagues, the urologist or the medical oncologist. We are independent, and we can take positions on behalf of our patients at the European level, at the European Parliament, at EMA, and at other places where legislation is created for European citizens on health, specifically on cancer and prostate cancer.
This is powerful. From their needs, how do prostate cancer patients differ from other cancer patients? And what should thus the medical and scientific community be mindful of? How should, for instance, the care pathways be improved for better prostate cancer outcomes?
Yeah, well, there are 2 old sayings on prostate cancer. One is, it's an old man disease. Quote none. Prostate cancer is a disease that hits men nicely below 50. So our treasurer at the moment, he was 48. I was 50 when I was diagnosed with high-risk prostate cancer. So it is also a disease for younger men. And we see more and more of these cases. So where the classical belief was, it's for old men, we have to adopt a new reasoning and say we also have to take care of men who are young, 50, below, around 50, who are still actively working. They are not retired, all of them. They have children at school age. So my children were still in school when I got diagnosed. This is a completely different situation from a person, a man, who only has grandchildren. His grandchildren are in school. It's different. So that is one of these big differences. Another classical belief is that prostate cancer is something like benign. It's not too bad. You can have prostate cancer and you can live with that. You will die with it, but you will not die from it. Now, the 70,000 men that die in Europe every year from prostate cancer, let's say, contradict that position. Prostate cancer can be really a bad cancer. It can kill men. So we have to adopt our reasoning and the way we look at the disease and the patients, which again brings us to this early detection. If we can find men when they are curable, and that's only if the cancer is found in a localized stage in the prostate, then we can cure it. If it goes out of the prostate and becomes metastatic, then it's game over. We can try to control it as long as possible with hopefully good quality of life, but we cannot cure it. These men they can die with it if the metastasis is late enough. but they can die from it, 70,000 in a year at the EU level.
Strong learning. Theranostics, also called radioligand therapy, is an innovative approach to treat prostate cancer. So let's understand it better and look at an illustrative video.
Radiotheranostics seamlessly integrate diagnosis and treatment. You see what you treat and treat what you see at a molecular level. This relies on the key lock principle. First, a radiopharmaceutical, which is specially designed to fit a unique receptor on the surface of cancer cells, sends out a signal allowing physicians to identify and image the cancer cells. Then, a different radiopharmaceutical delivers a therapeutic dose of radiation and destroys the cancer cell from the inside, without harming surrounding healthy cells. This targeted therapy is highly effective and can lead to nearly remission of metastasized tumors.
What is actually the position of Europa UOMO in terms of novel therapies such as RLT?
So we have, if we look back a little bit to 2001 when I was diagnosed, at that time we had androgen deprivation therapy, radiation, and we had surgery. Nothing else. So since then we have seen the advent of many treatments, many modalities that could help patients, always in the metastatic stage. So we are really welcoming any treatment that will fulfill giving patients better quality of life as a result of the treatment and hopefully a longer overall survival. And if we look at what we have today in radioligand therapy for prostate cancer, then we see that both of these conditions are fulfilled. So we see that patients who are eligible for radioligand therapy in prostate cancer, they are bad patients. They are really sick. They feel bad and they had all the possible treatments, which is a condition. So they had ADT, ARPs, they had chemotherapy, and they progress under all these treatments. So their cancer is escaping. They can be treated with radioligand therapy if the marker PSMA is present. So that's Theranostics, that's a condition. And if they are treated and respond well, they don't all do that, unfortunately, then we see a shrinkage of tumors, which has as a very important consequence that there's less pain for the patient. So the pain release from shrinking bone tumors is extremely important. And the second is that the patients have a longer overall survival. So these two are what we want. Of course, we are never satisfied with the range of overall survival, but we will see in the future. Because we're working now with lutetium, perhaps if we use other isotopes, it might be better. If we use more than the PSMA as marker, maybe there's another marker, because the problem with prostate cancer is that it is what we call a polyclonal cancer. So you have at the same time tumors who express PSMA and you have them who don't. So only the tumors that express PSMA can be treated and will be destroyed with this Theranostics. The other tumor will escape and he will perhaps 3 months later, 6 months later, a year, he will grow back and he will cause perhaps the death of the patient.
In this perspective, how do you envision the potential collaboration opportunities between Europa UOMO and the ICPO Foundation?
Well, a new therapy always has the problem that it has to be introduced. So not only in the professional world, which is done by the professionals. So the nuclear medicine doctors, they are talking about this because it's something very important for them, but also for the patients. So they know what it is. But it's also important that the other professionals learn what it is, because a patient who qualifies for the treatment has to be referred. And it's the other doctors, the urologists, the medical oncologists, who have to say, oh my God, this is a patient who could benefit from radioligand therapy, so I should refer him to the radioligand team so that he can be evaluated and potentially get this treatment. And then there is the group of patients. Patients need to learn also about these new therapies because it is a radiation. That means that some patients are afraid. But they should learn and understand that this radiation is extremely local, which is completely different from external beam radiation, which they might accept. It's completely different also in dose. So if you bring the dose to this very small cellular level, much less can do the job. So they have to learn that so that they have faith in what's going to happen. They have trust in those who apply it and that they know what to expect. So they cannot expect cure. Cure does not exist in that stage, but they can expect, hopefully, that their pain will be much less and that they will gain months in good quality. Because pain is one of the drivers of bad quality of life.
With respect of novel therapies such as RLT, what is the importance of patient registries in your eyes?
Well, so we have these clinical trials. They are the origin of the evidence. And as you know, I am in the Guidelines Committee of Prostate Cancer Treatment of EAU. We only use evidence to change clinical practice. So we need these clinical trials to find this evidence. But the downside of it is that we use a highly selected patient population. So these patients do not have kidney failure. They cannot have liver problems. They cannot be obese. They have to be perfect patients with only far advanced prostate cancer. They can do it. So we learn in a clinical trial how they respond to the treatment, which is the basis of what we then later use. But after that, the clinician is confronted with a man who is diabetic and obese. And the question, will this specific patient benefit from this treatment? So he can treat him. And then he learns, doesn't work so well. We need to up the dose, or we have to bring the dose down, or we have to wait longer. We learn. But this information should then go into a registry in which we bring in every patient in advance so that we are not only taking the good ones, and then we learn, and in the end we might say, look, patients that are super obese will not benefit. So we shouldn't treat them with this novel treatment. It's the same for all novel treatments, by the way, not only for radioligand therapy, but it is a registry gives us the opportunity to learn in the real world what this treatment does for a patient, how his quality of life is evolving, what his real overall survival is. And then we can use that information to decide for a wild-type patient who drops into a nuclear medicine doctor with a question, can I have, where he can have a real discussion that says, yes, you can have a benefit, but it will not be big because.
So this is very important.
It is very important. For us, it's very important that registries would be created, that they would be well done, so that the correct information is collected of good quality. Because registries, the problem with registries is very often that the quality of the data is not super good. So it has to be very good. It should be monitored so that in the end, we really have a tool that helps us improve the fate for the patient.
Very important, thank you. So the Europa UOMO has a very interesting initiative called the Academy. Could you tell us more about this and especially how it benefits ultimately to cancer patients?
So I told you at the start that we have to serve our community. And one of the things that we therefore do is we organize trainings for them. And the Academy is our training center for European patients. And at this moment we have two. One is the winter school and one is the summer school. Now they both serve a specific subdomain. The summer school is training patients really into prostate cancer. They are learning from diagnosis from basic chemistry, basic science, all the way to end of life. They are learning what is prostate cancer, and they learn it from a top faculty. Most of our faculty comes from the Guidelines Committee. So they all use evidence. So unfortunately, we cannot have alternative medicines. It's only evidence-based treatments. And it takes 4 days. They come from all over Europe, and Europa UOMO is sponsoring that. They are with us door to door 4 days, and they cannot go anywhere. So during that, I'm the director of the school. They are mine. Then we have the winter school. So they become expert patients in the summer school. The winter school is now where you learn how the European and member state medical healthcare system is constructed. So they learn what is the function, the role of European Medicines Agency. What is the role of your own federal agency on medicines in your country? What is their responsibility? A lot of patients think that the European Medicines Agency is there to allow clinical trials, which is not true. Clinical trials have to be allowed by your own member state. So they learn all these things. They learn in depth what is a clinical trial, a little bit about the statistics, about the epidemiology of prostate cancer. So they learn all these things they could use to confront their politicians. So if the politician would say screening is not working, wait a moment, and they can show the data, they can discuss the data with knowledge. They have the expert knowledge of the summer school and the expert knowledge of a patient advocate. And there will be other schools in the future. But that's where we are now. And so far we had 75, in 2 years, 75 patients from across Europe who attended summer and winter school.
Very nice. So as a wrap-up of our interview, what would be your personal message to a man recently diagnosed with prostate cancer?
So my message to someone who's recently diagnosed, because he already knew, I hope, of prostate cancer. So there are 2 situations. If he is diagnosed in a localized stage, I would say, inform yourself and then choose your treatment, because there are several possibilities. Trust the clinician and have your treatment. There are no guarantees, but the patient should know that. If, however, and unfortunately, the patient is diagnosed in a metastatic stage, then is the question different, because in that case, we have to inform the patient that at that stage, a cure is not possible, but that there are treatments available from which he has to choose, and that is shared decision-making, choosing with the clinician, so that he will have the best possible quality of life for as many years as possible. So long overall survival, or survival for the individual patient, and a good quality of life. So really inform yourself, learn from the treatments, and then with your clinician, make your choice. And again, have faith and go with your clinician that you have selected and the treatment you have selected. And we don't know where it will end, but it can end very well.
Thank you so much, Erik, for this very insightful and enjoyable moment spent together. This was excellent for me, for the ICPO Foundation, but also for our audience today. So we are really grateful. Thank you for that.
Thank you for having me. Thank you.
You're welcome.